Visitation hours have now ended. Please return to the main lobby to fill out the information desk. Again, visitation hours have now ended. Hi, everyone. I think we'll give everyone a couple seconds here to join in before we kick things off. All right. Well, welcome everyone. I'm Taryn Patricus. I'm the Deputy Director of the National Blood Clot Alliance, and I'm excited to welcome you all to the webinar today. We really appreciate you taking the time out of your very busy days to attend today's program, Thrombophilia Testing for Clinical Management. Today's webinar is hosted by the National Blood Clot Alliance, thanks to our generous support from our webinar sponsor, Grifols. It's also my privilege to introduce Dr. Caroline Cromwell, who will be moderating today's webinar and discussion. Dr. Cromwell is the Assistant Professor of Medicine at Icahn School of Medicine at Mount Sinai and the Medical Director of the Thrombosis Services Program at Mount Sinai Health System in New York City. She's also a member of the National Blood Clot Alliance Medical and Scientific Advisory Board. So welcome, Dr. Cromwell.
Thank you so much. Thanks for having me. I'm really excited to be here to talk about this really important topic. Before we begin, we have a few housekeeping items to take care of. We'll be taking questions from the audience, so please feel free to submit your questions anytime during the webinar. We'll be answering them at the end. There's a Q&A function at the bottom of your screen. The webinar is going to last approximately an hour. Please note the webinar is being recorded. You can go back to the site and it can be viewed at a later date as many times as you'd like. Before we start, we'll have two brief poll questions so we can learn a little bit more about the audience that's with us today. So please select your responses. Here are the questions. Number one, how'd you hear about this webinar? Email, Facebook, Instagram, LinkedIn, Twitter, or other. The second question is, which of the following best describes you? Healthcare provider, public health professional, person with DVT, PE, or family member, or member of a community-based organization. We'll be getting answers to these. Okay, looks like majority of folks heard about this through email, but from all types of social media as well as other. Question two, which of the following best describes you? Looks like we have a smattering of everything, but almost 50% healthcare providers, as well as happily, we do have also many either persons who suffered personally from DVT, PE, or family member. It is really great to have so many patients also interested in learning about this topic, about thrombophilia testing. Today's presentation was developed for a clinical audience, but we also see that patients are on board and really interested in learning. And that really is great because it shows patients want to be active participants in their care and management, working with their clinicians. I wanted to say that really thrombophilia testing it can be a controversial topic. Which patient it should be performed on, the who, what, when, where, and why of it is really can be quite murky. And how it affects patient care and what guidelines are telling us to do can be quite controversial. Patients, as we know, don't follow the textbook, and each patient case can be quite nuanced. So I'm really happy to introduce our presenter today, who barely needs introduction. But I'm really glad we can discuss it with him today. Dr. Kouides is here with us, and he is a leading expert in the field of thrombosis and thrombophilia. He is the Medical and Research Director of the Mary M. Gooley Hemophilia Center, attending hematologist at Rochester General Hospital, the Clinical Professor of Medicine at the University of Rochester School of Medicine, Clinical Associate Professor of Medicine at Roswell Park Memorial Cancer Institute in Rochester, New York. And finally, Dr. Kouides also serves as member of the National Blood Clot Alliance Medical and Scientific Advisory Board. Welcome, Dr. Kouides, and let's begin.
Thank you, Dr. Cromwell, and I would like to thank MBCA, led by the president of their board, Leslie Lake, and Taryn Patricus and Julia Thompson for putting this together and for support from Grifols. What I'm going to do in the next 40 minutes or so, a little bit less, because we have also a case presentation and a patient who will also share her perspective about this, and we'll have, hopefully we will want to have time for questions and answers. So my first goal is to, let me just, I think I have to move that, okay. So my slides are not advancing. Okay, so you see the second slide, correct? Testing for inherited thrombophilia?
Yes.
Okay, great. So for a second, I'll leave my contact information. In the interest of time, if for some reason you can't jot it down, you can certainly reach out to MBCA, and they have my permission to share it if you had some follow-up questions. Some of this presentation is shared by my great and dear colleague, Jean Connors from Harvard Medical School, who has written extensively on this topic, including a seminal review in the New England Journal of Medicine a number of years ago. So my list is in a way not too long here, but it's pretty meaty in terms of there's a lot of details to fill in these various bullets here. And obviously, one is not going to give a talk about testing for thrombosis for thrombophilia without obviously referencing the great German pathologist Virchow. And this is ingrained in us in medical school, these three pillars of the triad, so to speak. And again, it's important to emphasize that, you know, patients by and large often have more than one risk factor. Usually when a fellow or a trainee presents a case to me of someone who's had a blood clot, we kind of play the game. Can you find at least 2, 3, or 4 risk factors that conspired to lead to the blood clot? So that's very important. And so we typically don't clot in a vacuum, so to speak. And certainly most of the focus today is in terms of the purple area here, in terms of this area of hypercoagulability that probably in many ways is a disproportionate part of the cause, though stasis, if we consider our epidemic we're living in terms of obesity, is also a major risk factor, and as well as the countless patients today who are undergoing surgery, that in itself can be a risk factor for thrombosis. But we're going to be focused primarily of what we could test in terms of hypercoagulability, and obviously we can then categorize that further. And again, this is very basic, of course, but I'm just just starting here as our base here, talking about inherited versus acquired causes. And again, you know, my well-meaning trainees, they really want to order tests, and they're bright-eyed and bushy-tailed. They want to look for inherited causes, and often they miss the boat. As they're ordering all these special coagulation tests, they're missing the fact that the person's BMI is 40, or the fact that they're over 50 and they have not yet had a colonoscopy, or in the case of a female mammogram, or in case of a male, a PSA. And they also forget that these factors can all overlap, and you can have more than one risk factor. So it's not all about just an inherited cause like factor V Leiden, but you can have on top of this other additional risk factors. So again, it's that perfect storm where everything comes into play. And certainly, our job as a provider is to try to focus and determine, can we identify a trigger? And so a trigger is often called as provoked Unprovoked in the medical literature, as our colleagues know, is idiopathic. I often joke at that part of the discussion with the patient if we're coming up empty, and half the time we really don't come up with an obvious cause, we'll call it idiopathic. And it's a little bit self-deprecating humor, but it's a reminder that there's still a lot of work to be done. We still have a lot that we need to learn about the causes of venous thrombosis. So in many ways, I'm the idiot. I still have to learn a lot. And I often joke that I'm a PGY 36. So that means I'm in my 36th year of residency. So if you do the math, that goes back into the mid 80s when I started as a resident, or what they call a R1 or PGY1. But anyway, in this context, one of the acquired risk factors is really aging. As you can see in this very stunning diagram here, both men and women, have an increased risk of blood clots. That particularly is more pronounced, as you can see, in men between ages of 55 and 75, and then there's kind of a catch up after that, so to speak. But certainly age and gender, do play roles. And for as much as today we're going to talk about testing specifically for causes that are inherited, again, it would be sloppy and remiss not to focus also on acquired causes, because again, statistically, that's more common than an inherited cause, or at least you could have a mild inherited cause like factor V Leiden, as we see in 1 in 20 Americans, and yet they may never clot until there's additional factors. So we can kind of think of these factors, kind of put them into two main buckets here that either are going to be transient or provoked, and obviously major surgery would be one of them. Someone undergoing major surgery that we could define as general anesthesia of more than 30 minutes, and certainly more involved surgery, abdominal pelvic surgery, neurosurgery, cardiac surgery, in that sense is a risk factor. Obviously, multiple fractures with trauma, the fractured tissue can, incite clotting in that regard. And then obviously we've learned a lot in the last, 3 years. Actually, we've learned about the past, because for as much as there was such a focus in the news about COVID-19 related thrombosis, it turns out with the first SARS-CoV-1 in the early 2000s, there were similar rates of thrombosis. So that was kind of a reminder that infectious diseases can provoke a very profound inflammatory response, kind of this triad of marked hypercoagulability with very high coagulation factors, as well as infection of the endothelium with the generation of nets, neutrophil extracellular traps, as well as activation of complement. So you have that triad that you can not only see with COVID-19, but for better or for worse, we'll see it with the next epidemic, because the next epidemic, pandemic, will be a novel agent again that will create a very intense inflammatory response in us, the host, because we've never been exposed to it. And this has also been seen in varicella zoster and other infections. But obviously the focus the last few years, understandably, given the magnitude, the scope of how prevalent COVID-19 infection has been on that. And for better or for worse, we kind of use a cutoff of usually it's greater than or equal to 3 days of not getting up and around. Not all immobilization is, the same. Obviously, if you're in traction, that's going to be more severe than if you're on your couch, with an illness, with the flu, so to speak. And then certainly, estrogen is a transient risk factor, though we do come across, what do we think about those cases where someone develops a DVT after being on hormonal therapy for 20 years? That makes you wonder if there's other causes. Certainly, it's more compelling if it's a recent start of estrogen-containing contraception, like in the first 6 months. But as I've discussed this with my dear colleague Fritz Rosendahl, one of the world's VT epidemiologist experts, in their data, they clearly show an ongoing risk over decades. But partly because as one gets older, that's an additional risk factor. But classically, estrogen is within those first, certainly 3 to 6 months, up to 12 months. Beyond that, someone who's been on it for many years, it can be playing a role, but you start to be a little bit skeptical and think maybe there's other risk factors. And obviously, pregnancy kind of is the equalizer, because normally if you're not pregnant, if you're a female of reproductive age, your risk of a blood clot is only 1 in 10,000, whereas in a male, it's about 1 in 1,000. But once you're pregnant, it brings that down to the equal risk of about 1 in 1,000 because of various, factors of Virchow's triad, with the hormones causing hypercoagulability and then having stasis as the pregnancy continues in that regard. And then a very common drug that we use, heparin, we use millions of units of it every year in the United States, can induce immune response that can lead to not only low platelets, the T, thrombocytopenia, but also thrombosis. And again, as far as travel, those numbers aren't cast in stone, but certainly, studies, some epidemiological studies, not really good prospective studies, have suggested, however, about 4 to 8 hours, respectively. And my house staff often forget about smoking. They get a good history in someone who has a heart attack about smoking, but it also is a risk factor for VTE. As far as those risk factors that are remaining, that are not really transient, I already alluded to obesity is a big one, and obviously aging, and certainly this immune condition, APAS. And then, I don't really regard that as a true chronic medical illness, but I guess it could be lumped under cancer and these other conditions. But certainly cancer is a big one. Cancer is a big acquired cause, but also it's treatments that we use. Some of my colleagues on this call may not be aware that now Ibrance, that's used for metastatic breast cancer, can be prothrombotic. And inflammatory bowel disease has been known to be prothrombotic, about maybe 8% likelihood. Again, these people often have other additional risk factors about, if they're immobilized, with a severe flare, with abdominal pain in the hospital. And also a drug that's being used for it, an oral drug, Xeljanz, can also be prothrombotic. Not typically regarded as cancer, but the cousin of cancer is the bone marrow conditions, the myeloproliferative disorders, as well as PNH has a high prevalence. And sometimes someone with a clot, particularly if it's in an atypical site, like in cerebral vein or in the splanchnic bed, could be from PNH. And it turns out, for as much as we have learned over the last 2 decades, that one of the drugs for multiple myeloma, thalidomide, and then its congeners, lenalidomide and pomalidomide, can be prothrombotic. It turns out that prior to even getting those treatments, people with myeloma and even the pre-myeloma phase MUGUS can be, at risk of developing clots. And particularly as we know that myeloma and MUGUS is more prevalent in African Americans, checking for MUGUS with an SPEP should be maybe on your list, particularly in an African American who, obviously, as we'll discuss, won't have these other risk factors. And then nephrotic syndrome, sickle cell disease in that regard. And then kind of the third bucket is about 40 to 60% of the time we come up empty, as I mentioned. Some other points I want to bring up: progestins in general are okay, except studies from the MRC in UK clearly show Depo-Provera is prothrombotic. I'm not sure why, whereas we don't think as much oral progestin is prothrombotic like norethindrone, though some of my maternal fetal medicine experts think it may possibly be. Most experts feel transdermal estrogen because you don't have that effect through the liver to activate metabolites, is not felt to be prothrombotic. And in select cases, we have used it in people with a history of Leiden and prior clot. And then nephrotic syndrome, we forget about that, but we should start thinking about low-dose prophylaxis with Xarelto or Eliquis if they really have pretty extensive nephrosis with an albumin defined as less than 2 and or more than 10 grams. And then as far as other acquired causes, for as much as we think of AT3 protein CNS being inherited, they certainly can be acquired due to these conditions. And all these conditions can lower your level, so you can get a falsely low level in that regard. And I don't have, you can't see the camera in my room, but I have a sign that I also have in my lab that says repeat until normal. So you always want to, confirm abnormal results. and at least, particularly with protein CNS, 2 weeks it takes for the warfarin effect to wear out. But as far as inherited causes, most of the audience is well aware that we're talking either about a gain of function where you're increasing the procoagulant activity, the pro-clotting proteins, or a loss of the anti-clotting proteins in that regard. And the important teaching point here, as I've kind of alluded to, is that there's often, that perfect storm. It's not just being born with these genetic, thrombophilic conditions that's going to predict a clot. It's often being tipped over. So you may have the genetic predisposition, the genotype, but the phenotype becomes expressed. The phenotype, which would be the end result of it being a DVT or PE, being, triggered by these conditions here. And again, this is more of a basic slide that is just reminding the audience of how we, test for Leiden. At some institutions, unfortunately, partly because they're doing it on site and they can charge for it, they'll go straight to the genetic testing for factor V Leiden. But if someone is not already on a DOAC, you can certainly do the standard activated protein C ratio that is close to 100% sensitive. The only case is really that it's going to be negative if someone had a liver transplant. Then they have the protein C, the acquired protein C from that donor liver. But outside of that, the APCR screen is a very cost-effective screen. It's basically a glorified PTT where you're running a baseline PTT and then adding protein C and looking at the ratio. But in certain instances, especially nowadays, where most guidelines do advise using a DOAC as first-line treatment of a VTE or atrial fibrillation over warfarin, you can get around that and not take them off of it by doing the polymerase chain reaction. And sometimes the house staff asks me, hey, can we check a prothrombin level, factor II activity? And that kind of varies markedly. There's a lot of biological variation, though with this mutation, it should confer a baseline higher level, but that's that's more of an average higher level than normal. So you really can't rely on, prothrombin activity being 110% to be consistent with the underlying genotype. You really need to do the PCR. And we have the functional assays for AT3 protein CNS, and these can be done also as immunologic assays, so you can test while they're on a DOAC. Protein S is particularly finicky, partly because the total amount binds to is governed by a complement 4 binding protein, and that's an acute phase reactant, including under stress. So you have to be careful, particularly, if someone's having an acute clot and they have the stress of the clot, their protein S level can not only be consumed by the clot, but also can be falsely low because of a high C4b at that moment. And sometimes oral contraceptives also do the same and may explain part of the pathogenesis of COC-related thrombosis. Other causes that we kind of use our second, third, or fourth tier of testing, particularly in a young person, would be an abnormal fibrinogen. Very rarely would be true homocystinuria, not just cystinemia. This would be someone who typically is a male with a mental delay. Importantly, the most important part of this slide that I'm going to show is right here. Please don't test for these conditions. And there's a very nice paper led by Tom DeLaury at OHSU with Bev Hunt and Gene Connors, just came out in Research and Practice of Thrombosis Hemostasis a few months ago. And it's a call to action to you providers there. Just say no to MTRH testing. This has been more ingrained in the obstetric literature. And so consequently, we still have some obstetricians still ordering this, particularly fertility specialists when someone has recurrent miscarriages, but it doesn't correlate with recurrent miscarriages or with thrombosis. And it's very vexing because up to 35% of us have either heterozygous or homozygous mutation in MTHR. It does not correlate with thrombosis. So we really shouldn't be testing. Factor VIII in certain instances, particularly in African Americans, can perhaps be a risk factor, and I'll circle back to that in a little bit. It was popular for a while to do genetic testing for factor 13 as well as plasminogen activator inhibitor. Those really don't have any solid data to support its use for testing. Though again, some well-meaning fertility experts will do that when someone's had recurrent miscarriages, and you really, then are struggling with, trying to tell that very, motivated patient who's been told by the obstetrician that, oh, we found MTHR or we found factor 13 polymorphism, that's why you miscarried. Now you're going to see Dr. Kouides to prevent miscarriages. It's with a heavy heart that we have to tell the patient there isn't data to support, that, or to support treating this with an anticoagulant like Lovenox to prevent miscarriages, because it really doesn't correlate with recurrent miscarriages. And that also includes factor 12. We've had kind of a flurry of those cases in that regard. So this is kind of a summary slide of the various tests that we do and how common these conditions are. And for as much as, we're talking about genetic testing and whether we should do such testing, I do want to, point out that one test that should definitely be done if it's a unprovoked clot, in other words, we don't know what triggered it, is to really test for APAS. Ideally, if you could do it right before they start treatment, but that's easier said than done. Almost always you are hearing about these cases after they're in the emergency room or in the doctor's office or on a DOAC. And you obviously can't test for lupus anticoagulant on a direct oral anticoagulant. But, particularly if it's an arterial clot, you may want to at the very least get, anticarlipin and antibiotic protein antibodies. But either way, again, the rationale to test for APAS is particularly if all three of these tests are positive, your lupus anticoagulant screen, usually that second test in my institutions is still called clotting time. But if those tests are positive with the anticarlipins and beta-glycoprotein, what we call triple positive, a very well conducted study by Walter Pengo and his group in Italy, the TRAP study, clearly showed that warfarin was superior to a DOAC. And there's been several other studies that suggest maybe even if you're double positive or single positive, but I personally don't think the verdict is out in those patients. All of us, and I'm sure Dr. Cromwell is taking care of patients with either just a positive lupus anticoagulant and negative cardiolipins who were years ago placed on a DOAC and have done well. So there needs to be more studies of the double and single positives, but it's kind of morphed into the fact that even if you're a double or single positive and it's been repeated 12 weeks later, you probably should be on warfarin long-term instead of a DOAC.
Yes, that does come up. And something else, just to point out,
Yes.
so just to review that. So essentially you were saying with a new thrombus, you would tend to avoid sending extensive thrombophilia testing, except for suspicion of antiphospholipid antibody syndrome.
If you could get it at that time, right?
Right, send those tests before. And also to point out that antiphospholipid antibody syndrome is more likely potentially to affect venous and arterial cause venous and or arterial thrombus, much less likely so with the other thrombophilias, which if present affect the venous system.
What's interesting in this table, I also want to point out, is you can see the disparity between the prevalence of Leiden, 5% in Caucasians compared to non-Caucasians. It's much lower, as well as prothrombin. And the explanation has been is that the founder mutation for Leiden and prothrombin occurred after Africa broke away from Europe 20,000 years ago. And it probably was a favorable mutation, just like sickle cell trait is preventing malaria. We know that having the trait for Leiden or prothrombin reduces the risk for major postpartum hemorrhage and probably death. So that's why it stayed in the gene pool. But what's really fascinating is for as much as Leiden and prothrombin are far more common in Caucasians, at the end of the day, it turns out that Blacks have a higher rate of VT, 2 to 4-fold. Another way to reframe it is 30 to 60% higher incidence of VTE, which is fascinating because they have a very much lower rate of Leiden and prothrombin. And unfortunately, for those who develop PE, there's a higher mortality, and this seems to be separate from imbalances in healthcare access, though that is still, a factor, of course. If just like with the COVID pandemic, patients, were doing poorly in part because they didn't have prompt access to care, but there seems to be inherent some risk factors apart from that lead to poor outcomes. In that regard. And then there's been appropriately a lot of focus on pregnant-associated VT being higher, in African Americans. But it's fascinating because these patients have a high family history of thrombosis, and yet these families have a very low rate of having these conditions of Leiden and prothrombin. So there must be some other genetic risk factors or other factors that lead to perhaps some of these findings. We have seen, it was published years ago in Thrombosis Hemostasis in England, that patients of African descent had much higher factor VIII levels. And I don't know if, Caroline, you check factor VIII as a second or third tier testing in these patients, but I have done that occasionally and have seen, pretty high levels.
Yes, we haven't. Sometimes that is the only issue that we find that is elevated, and it still can be unclear, as you mentioned, if that's really what is at issue or not, and what to do about it. But it is absolutely true finding that Black patients, African American patients, have higher morbidity and mortality as well, and it is correlated in pregnant women as well with poorer outcomes. So it is absolutely an issue that still needs to be clear understood.
And the other issue is, what is the role of these chronic conditions that are at a higher prevalence? And so there's a lot of more, work that needs to be done. Again, when you do the standard thrombophilia testing, you're only going to come up with, abnormalities in about 20 to 40% of patients. So that has led to work, particularly done by Alfred Lee at Yale, where they do widescreen genetic screening. But this is not quite ready for prime time, but it is kind of provocative. In the interest of time, I'll just move on that when we do thrombophilia testing, we already emphasize that it's not helpful to do it right when they're in the emergency room with an acute clot, and particularly if they've already been prescribed a DOAC. Again, we can share this slide with all of you about some of the factors that affect, the testing. DOACs are pretty red here. So there's a lot of these tests you can do on a DOAC. You can do the antigen screening for CNS, but not the functional assay. Most labs do antigenic, but certainly the screen for factor V Leiden, you have to do the PCR instead. Also, a lot of patients have insurance companies that have made deals with national laboratories that require the sample being sent thousands of miles away. So that can also lead to a poor sample. But to get to the heart of what we want to discuss today is who should have testing for conditions like protein CS, AT3, factor V Leiden prothrombin gene. Historically, we're taught in medical school, Caroline knows, under age 40, but there's about 20% of people with AT3 CNS deficiency that could present a little bit older, between age 40 to 50. So some people go as high as 50. That's the new normal, I guess. But classically under age 40, particularly if the clot occurs with very minor risk factor. A great example is, for as much as we know a hip replacement is a major risk factor, arthroscopic surgery is a minor risk factor. And if you get a DVT at age 30 as an athlete, having some cartilage cleaned out, and you get in that setting, it does make you wonder that there's underlying thrombophilia, particularly if there's a family history or recurrent, or if the clot's showing up. On the other hand, for as much as Leiden is common, seen in 1 in 20, what's interesting is that the risk factor of a recurrence of a clot, once you uncover Leiden, is not that high. The ratio is about 1.3. And usually we get excited if the ratio is, in the 2 range or higher. And in another study, a subgroup analysis done by the Canadians also showed if you had underlying thrombophilia, that did not predict the risk of recurrence. So because of that, some people have opined that maybe we shouldn't do genetic testing, when you present with a clot, particularly if it's provoked. On the other hand, there's an argument to do it in terms of, closure, the need to know. And also, if you have an underlying condition like AT3 screening, family members, particularly if they're on COC or, presently pregnant, particularly in severe AT3, you'd consider AT3 concentrates. And again, there's reasons, why you certainly shouldn't screen right at the get-go. And then there's also that British maxim that, why do the test if you're not gonna, why test for Leiden since it doesn't increase the risk of a recurrence markedly? It's not going to influence your decision-making for long-term anticoagulation. So for all these reasons, there's been incredible controversy, regarding testing. We're not going to solve it today, but hopefully, we can suggest a more nuanced approach. Even close to a decade ago, our colleagues in the American Society of Hematology, as part of their Choosing Wisely campaign, this is very appropriate, certainly, with provoked clot, not to consider it, but things are changing a little bit, and I'll touch about that. And then the other challenge, of course, is that you can have misinterpretation of the results. We talked about laboratory artifact, about falsely low levels during an acute clot, in that regard. And then at the end of the day, there's other risk factors we need to know. That we haven't yet discovered. And so the family history can be a risk factor in itself, even though they don't have identifiable Leiden or prothrombin or protein C or S deficiency. So along those lines, why should we test or why shouldn't we test? Certainly the first bullet is a reason why not to test, that the role has not yet been well defined. On the other hand, if you can affirmatively answer the question, why does it change care? Unlike the British maxim, if you are going to do something differently, or if it's just for, closure, then these are good reasons, to consider testing. But in general, if it's a provoked clot for major surgery and the like, it's not really going to influence how long you're going to treat them. You're still only going to treat them for a limited time. And if it's a malignancy or if they have APAS, they'll need long-term anticoagulation, or at least if it's malignancy, until, they're in a remission. In the remaining time, I'm just going to bring to your attention, and you can Google this. You can Google 2021 ASH draft thrombophilia guidelines, and you'll come up with a very long document that does have some very controversial areas, and that's why it hasn't yet been finally approved. Whereas the British guidelines by Deepa Arakhlaj and my dear colleague Mike Laffin is really available, for prime time for viewing by all of you. I think this is also free access through the British Journal. So you can also Google 2022 British Society guidelines. Some of them are very similar. So in both cases, they don't really suggest testing for, Leiden or prothrombin or CRS or AT3 routinely, or in family members, for the simple reason that, there's other factors that are going to guide your decision regarding the duration of treatment. Particularly, as we said, Leiden doesn't have a very high risk factor, though sometimes if you're really in a quandary whether to continue long-term anticoagulation, particularly in a male who's very reluctant to stay on it, though in general we suggest males with an unprovoked clot should be on it, sometimes testing for Leiden or prothrombin, if positive, may finally, in a way, convince them to stay on, anticoagulation in that regard. So the guidelines are quite similar for an unprovoked clot in general. They don't suggest, but again, there are instances, particularly in a young person at a young age. That's oxymoron there. So in a young person, particularly with a very extensive family, there may be a need to know in that regard. And in the ASH guidelines, this kind of makes sense that, you don't have to test. On the other hand, the guidelines have many very controversial parts. Look at this one. This is stunning. So they say if you have a clot that's provoked, and again, it's a little bit verbose here and wordy, what's a non-surgical major transient risk factor? Here's the list. So I think in general, Dr. Cromwell and I typically wouldn't do thrombophilia testing in such a patient, particularly if they, had the flu and they were in bed for 3 days and they had a clot. Because such patients, I don't think neither of us would put them long term on anticoagulation. So these haven't yet been approved for final review. Both the Canadian group and a group of U.S. Experts have written to ASH objecting about this because certainly the data isn't very high level to support this recommendation. And then another one that's also, there's two that are particularly controversial. Dr. Cromwell and I typically wouldn't leave somebody on, anticoagulation after they have, a blood clot in the setting of pregnancy or after delivery, just because they may have Leiden or prothrombin gene mutation. So unfortunately, these draft guidelines, they didn't supply all the primary systematic reviews. So we're anxiously waiting. This really, I think, probably is going to raise the hair on the skin of many of the providers listening to this presentation today. So I'm just throwing it out there that be prepared. This may come out as a definitive voted guideline, and then we're going to have to kind of be like the clown at the circus following the elephant, cleaning up this mess here, because I think Dr. Cromwell would agree. You probably wouldn't commit somebody to long-term anticoagulation just because, they had a clot from pregnancy or COC. Obviously,
Yeah,
if they,
absolutely.
yes, go ahead, please.
No, absolutely. In the setting of something we would consider provoked, essentially, we would have considered this a provoked thrombus. To put a woman on long-term anticoagulation lifetime would not normally be something we would do.
And for better for us in the context, we're within minutes of having our panelist present her story of cerebral vein thrombosis. But for better for worse, the ASH guidelines also stated, even though someone may have a family history and they're going to be prescribed contraceptive, you don't need to test. And I think, our panelist story would suggest otherwise. Again, I can, in the interest of time, share these slides with you, but this is again, you could just Google Gene Connors, New England Journal 2017. This is a very nice diagram. Obviously, if it's a strong trigger, some of this requires, having gray hair and some experience to decide what is a strong trigger. Is a, car ride from, Rochester, New York to the Jersey Shore, 6 hours enough to, trigger this? Hard to say. Obviously, a very long car ride to Florida, that's different. And then again, if it's a weak trigger, again, you have to have a discussion with the patient, also with the insurer, because we get pushback. Dr. Cromwell and I get pushback from insurers to often not cover, these testing. Some of these tests can add up to $1,000 or so. And obviously, if it's unprovoked, we certainly talked about considering for APL. And then someone with a cerebral vein or a clot in the hepatic vein, portal vein, or mesenteric vein, should be splenic vein should be tested, for these conditions in that regard. So as I finish up here, some summary statements. Again, it's very nuanced. When you get a clot, there's more than one cause often, and your job is to kind of tabulate the causes and kind of weigh which is the stronger and which is the weaker one to help you decide, particularly, on testing. And it's important when you talk, one of the biggest challenges when I have, the trainees see a patient, their short list of what I want them to accomplish when they interview the patient is to decide what should be the duration of anticoagulation. And usually it's not governed by genetic thrombophilia. It's usually going to be governed, by these other issues that are included in these, risk assessment models in that regard. And again, this is very nuanced. Dr. Cromwell and myself and other colleagues on the National Blood Clot Alliance, we're always happy to, give our input, except when we're busy raising money for Leslie Lake and Taryn and the group. And so I will end there. Again, this is a really nice review of, some very important bullets that you need to really take into consideration. So in the interest of time, I'm 5 minutes over time, so I apologize. I'm going to turn it over to Taryn and Julie and Dr. Cromwell and our participant. I will unshare my screen in a second. So you could
Okay.
start. I'm just going to let people digest this for a second before I unshare.
Yes. All right. And also remember, this is recorded. We went through a lot of information, so you can re-review.
And I just want to add, there are some cases at the end that I didn't have time to share, so
yes,
they could review those too if they would
yes,
like.
definitely. Those are, I looked at those. Those are great cases. Thank you, Dr. Kouides. That was really informative. I also love that you added that, what you're calling young is going up in age, because I really want that to happen. But also, we please keep adding questions to the Q&A. We will try to get to those. I know we're a couple of minutes sort of longer, but hopefully we can maybe add a couple of minutes to the end, so we can try to get to everything. So we've reviewed guidelines, indication, but of course, all of this, in the end, it's all about patients. And if you can imagine that this can be murky as clinicians, then you can think about it for our patients, how navigating this can be murky and difficult. So I really want to thank and introduce Catherine Vaseli, a patient here today who we really appreciate you coming and willing to share your story with strangers today to help us learn from you. So thank you for joining us today to share your story and perspective. Will you please tell us about your experience?
Yeah, you're welcome. Thanks for having me. So I was diagnosed with prothrombin gene mutation and factor VIII in 2017. And but my story first kind of starts 15 years prior to that. I was put on an estrogen birth control at the age of 17. And when I was put on that, my provider didn't ask anything about my family history. Although had she asked, I didn't have any family history that I knew of any blood clotting or anything like that. So I was put on an estrogen birth control, and I was on that for 15 years without any other provider, going through different providers, no one ever questioning it. And then 15 years later, I had 2 strokes within minutes of each other. And it came from cerebral venous sinus thrombosis, the CVST, and both clots had broken off. And the first one was an ischemic stroke. And the ischemic stroke then caused me to have a seizure, which then caused me to have a hemorrhage, a brain bleed on the other. So it was both frontal lobes. So I was taken into the hospital. And at first they just knew that I had a seizure because I had bit through my tongue, and they didn't really know what else was going on. I just had all in my file was a history of migraines, and that's it. And I had only had 1 MRI done, and that was at the onset of my first migraine when I was 19. So when I came into the hospital at the age of 32, and they realized that I had had 2 strokes, and they saw the infarction on the right frontal lobe and the brain bleed on the left frontal lobe. It took until the second day for them to figure out that they needed to do an MRV and an MRA, not just CTs and MRIs. And they saw the CVST back there. And then on the second day, they finally did the blood testing and saw that I had the prothrombin gene mutation. And essentially they said that it was just that alone. It was heterozygous, so it was only one of my parents. It was that plus being on the estrogen birth control for 15 years that caused these clots. They essentially said that they had been growing for probably about 10 years. And they knew that because I've had 3 thrombectomies that all kind of failed, essentially. They didn't, each one just got a little more aggressive, a little riskier. And And every time that my neurosurgeon went in, he essentially said, it's almost like scar tissue back there. We can't, get any of the clots really out because they've been growing for so long. And in that time, with the migraines, I just was never, it was never a question of, testing for doing further testings on my head or looking for maybe it's clots, that's maybe what's causing that.
And the migraines during evaluation for that. So what you're saying is during that time, you had never sort of been evaluated with any imaging or.
Right. So I only had one image done, and that when I was 19, and that was my first migraine, and they didn't see anything, and then they didn't do imaging again until my strokes when I was 32. So essentially, my takeaway basically from this whole experience was that had I just been tested before being put on birth control, because estrogen-based birth control on its own can cause excuse me can cause clotting. And so I think that, so I'm gonna grab some water, my voice is going here. So when you were speaking about the reason you sometimes don't do tests is if it would not change the course of care. And that's why I think that it's important for providers to think about, if a woman or a girl or someone that has a menstrual cycle comes in and wants to be put on estrogen birth control, that even if they don't know their family history, there's a lot of reasons that, a young person wouldn't know their family history. Or if they do, it's limited and, it's not, nothing was present that stands out, that you could test for, this prothrombin gene mutation or, one of these thrombophilia inherited risks. Because if you were to test positive, that would then change the conversation as to whether or not you would go on this, estrogen-based birth control. And I think had I had a test done, way back in 2002, I wouldn't have done an estrogen birth control.
Right.
I think that's a big issue.
Dr. Kouides, I will say I have had some patients, and it is in the aftermath, but who have had either a different thrombus, and in their history, it will be that they've had migraines on birth control or things sometimes in their history such as that. I was wondering if you've ever experienced that or heard that.
Certainly, we've seen complicated migraine with antiphosphate antibody syndrome. There's a number of reports that suggest that can be a risk factor. I don't know about you, but certainly if someone has a family history, and they're concerned before starting oral contraceptive, we have done testing. Sometimes what happens is the well-meaning obstetrician does the testing, and they include lupus anticoagulant and anticardiolipin, and then we're asked to see the patient because they have a high cardiolipin or a lupus anticoagulant, and those are the wrong tests to do with a positive family history, because those, as are not directly. So sometimes the testing can be incorrectly done, but certainly with a positive family history, I don't think it's unreasonable, even though the guidelines state they shouldn't be. As far as no family history, like in Catherine's case, as I mentioned, the guidelines would say not to do such testing, even if you have a positive family history. But again, I think you have to individualize the patient's concerns and the like, in that regard. I think we mentioned on our pre-conference call, there is a there was a study from the Canadians that if you tested all women, even without a family history, for factor V Leiden, you would deny oral contraceptive to 20,000 to prevent one fatal pulmonary embolus. But, you know, that's kind of a, you know, cold calculation, but I can certainly see, you know, the patient side of it too. Right now, as you're aware, in the United States, it's hard to get approval for testing, particularly if there's not a family history. Has that been your experience, or?
Yeah, yes, it can be very hard. And I think Catherine even mentioned for your sister that it was hard for her to get approved even with your history.
Yeah, that should have been approved. That, you know, we would
Yeah.
definitely fight for that. That's unfortunate.
Yeah, she she went in and they told her that she had to have two immediate family members having blood clots in order to be tested for it. So she had to go back a second time because she's a female and she has a daughter. So I just wanted her to be tested. So I just think that, you know, to expect someone to come in wanting birth control, you know, a lot of young women
Right.
do that. And for them to come in knowing their family history, I don't think that's really realistic. So
Right.
I almost think that it should be more of a conversation where, you know, if the OBGYN doesn't know which testing to do because of what they're prescribing has a risk factor standalone, you know, on its own for clotting, they should know which test to use, what to test for. And then, you know, even if it's, you know, you said, you know, 20,000 or something, if we tested everyone, but then they would know and that would be their decision.
Right. I mean, so it sounds like some of the things to, you know, appreciate from your story, and I'm sorry for the things you have gone through. And again, thank you for talking with us about it, or that, you know, really having clear conversations with your provider. I mean, to the extent that it's even that, you know, I'm not sure without your history what the risks might be, really understanding the risks of oral contraception, knowing even within family members, when you do know, just knowing what can affect, or testing when it can affect life choices from pregnancy to the use or not of birth control. But for all of us, just recognizing how really complicated these can be and that there's still just no great answers. I do want to try to get to some of the clinician and patient questions too in our time. I think some of them are related as well. We have a patient question here, Dr. Kouides. My factor levels are elevated, greater than 200. That's the only thing we found to explain my unprovoked DVT-PE. What can cause elevated factor VIII levels? From what I've seen, Dr. Kouides, and please jump in as well, oftentimes we think it's sometimes related to other inflammatory conditions, other chronic illnesses. Dr. Kouides, do you have any other thoughts?
Yeah, sometimes we'll kind of double check that value by certainly repeating it more than once, as we joked, repeat until normal. And we'll also, you know, sometimes check a concurrent C-reactive protein level. That's another marker of inflammation. And we'll remind ourselves that as hematologists, the blood goes through all the organs, as Dr. Spivak has written about, and that there can be other, you know, inflammatory conditions that can cause this. That may be the bigger issue. Whether the factor VIII in this range clearly is the cause of the clot, you know, is not settled at this time.
Right, and that thrombus, right, should be treated as an unprovoked DVT-PE.
Right. Yeah, I would probably lean towards that, but it's kind of like with African Americans, they have a higher prevalence of chronic conditions, CKD, hypertension, diabetes, and those in some way are inflammatory states. So with metabolic X syndrome. So maybe that goes hand in hand with the high factor VIII, and maybe that's the case in this patient. Maybe they do have one of those chronic metabolic conditions. Or
Okay, next question. In case of PNH with thrombosis, which would be preferred choice of anticoagulant? So at least in our institution, basically, it does seem with PNH with thrombosis, it's an indication for the choice of anticoagulant. It's more really about that as you treat the PNH with anticomplement therapy, that's how you're really decreasing the thrombotic risk. Not that there's a true choice of anticoagulant that matters as much as that as you treat the PNH with anticomplement therapy, that's what decreasing your thrombotic risk.
No, I agree. That's the most important issue, but obviously they'll need, initially,
Of course,
antithrombotic
anticoagulant.
therapy.
Yes.
And in those cases, I don't think, and you probably agree there, I don't think there's been a danger signal that DOACs are perhaps inferior to warfarin like APAS. So we've been comfortable using a direct oral anticoagulant.
Yes. Okay. Where can you see and review the information for this? I hope you see and review it many times. I believe you can find links on the website and our channel. There's a YouTube channel for us. Can you have a tiny gastrocnemius vein blood clot with a negative D dimer, and is it considered a DVT, and does it require treatment with Eliquis or Xarelto?
Well, that's a good question. So I'm a PGY 36, as I said. So in PGY 1, we wouldn't have done treatment. We would have maybe done a follow-up. I mean, they were just starting to do ultrasounds back then routinely. We were still doing venograms. But I think most of us still would consider treating it if the ultrasonographer feels, there are changes that are consistent with an acute clot. In other words, what they're seeing, the occlusion is more in the center of the clot. They're not seeing eccentric thickening of the clot. Probably a short course of anticoagulation, even though the D dimer is not elevated. If it's clearly a history of an acute clot, if it's, on and off pain for several months, it may have been, a while back and you may be past the window. But nowadays, since DOACs are easy to use and if the bleed risk in the patient is low, it wouldn't hurt. What would you suggest, Caroline?
I agree with you that a short course of anticoagulation is usually what is instructed. Catherine, there's a question for you. What contraceptive were you using? If you feel comfortable.
So there was a couple. It was I believe Yasmin, and then the Yaz, and then when it was then I think like rebranded, or it was like the lower dose of something. I think it was Yaz. The one, yeah.
Which is a higher risk.
I believe the Yasmin, right, Caroline's been taken off the market because it's a fourth generation and it's the progestin dysperione that clearly did increase the clot risk.
Yeah, that is a high risk.
So that one I started in 2002, and then I'm not sure which year I was switched on to the something different. I think it was just, it was called Yaz or something. I don't actually remember, but I was taking off it completely in 2017.
Okay. Here's another patient question. 2 years ago, I got a DVT after a 6-hour car ride, tested positive for thrombin gene mutation, heterozygous. The hematologist recommended to get off of Eliquis after the clot cleared. The vascular specialist and my primary said to stay on it for life. I've been on it for 2 years, taking 2.5 twice a day. Any recommendations? Will there be a cure for this at some point down the road? Gene therapy to cure completely. Thank you. I will let Dr. Kouides take this, but obviously we do not know kind of everything about you, Mr. Manning.
Yeah, that's so this is a good example of the perfect storm. In other words, there's more than one cause why they clotted. 6 hours, if you look at the Canadian retrospective analysis of their data, is below the 8-hour cutoff, but 6 hours plus prothrombin probably conspired together. if this was my patient, we would stop treatment after, usually 3 months. If the ultrasound, we always get a new baseline ultrasound, not as much to help me decide if I need to keep them on anticoagulation, but as a new baseline. And then if they're going to take such trips in the future, I would just have them take Eliquis or Xarelto low dose beginning 2 days before and continuing 2 days upon arrival, and then repeat the cycle. If, however, they're just going for a week, they could just stay on low dose Eliquis or low dose Xarelto for the duration of the trip, 2 days before and then 2 days upon return back. Again, this is what we call ABM. It's not EBM, evidence-based. It's anecdotal-based or attending-based medicine. But I think, Carol, a number of our colleagues do this, so I would be comfortable in this case. If there's great concern about going off, this may be an instance where you may want to get a baseline D-dimer and check it 6 and 12 weeks later. But I think that's over the top. I don't know. What do you think, Caroline?
I mean, I agree. It doesn't seem unreasonable. There was quite a trigger with the 6-hour car ride that you would not necessarily have to stay on this for the rest of your life. So I do tend to agree with the hematologist. You could certainly see one to get another opinion. And this is without knowing all your other potential medical problems, but I agree that in this setting, it does seem in more high-risk settings, you could be on the Eliquis.
Right. If there's other multiple risk factors like a
Right.
BMI over, say, 30 to 40 or bad varicose veins and leg swelling, that's a different matter. But if it's just prothrombin in the 6-hour ride,
Right.
remember, majority of people with prothrombin don't clot by age 65. So as long as precautions are taken, if you end up on crutches or a cast, you should go on
Right.
Eliquis, low
Exactly.
dose during that.
Yes. Exactly.
So I don't think you have to be committed to long-term anticoagulation.
Yes. Yes. Catherine, I think there's another question for you. If you were told about any risk with pregnancy.
Yes. So I I have been told that I cannot have a child, that I can't carry my own child and give birth because it's too risky, because of how many and how much of my venous sinuses are clotted and how far down it goes. And so, yeah, they have recommended against giving birth, carrying a child.
Yeah, I think, in cases like that, it's always good to get additional input. If you're in the New York City area, seeing a certain person at Mount Sinai, or, as well as in conjunction with maternal fetal medicine experts too. Not all of them are, as comfortable taking care of patients with these conditions. And there's several great ones, in the New York City area, for example. So.
Yeah. Well, I mean, right, just in general, being sure. Well, and for anybody out there with very highly complicated issues, just seeing people who you feel see patients who see patients with, very high risk, particularly around pregnancy and blood clotting or things like that in general for your care. Have you been diagnosed with have you diagnosed patients, I'm sorry, with a COVID vaccine induced clot?
Caroline, you could go ahead first. We haven't had any cases of it here, but
we have seen patients where it seemed to be yes, it seemed to be the only associated risk factor. Again, based on sort of data analysis of COVID vaccines, it seems the numbers may or may not be statistically significant, but it did seem in some younger patients, but they may or may not have had other risk factors, such as being on oral contraception and then receiving a vaccine. So it can be very difficult to tease out what was associated with the vaccine itself. or the vaccine alone. In any case, patients do receive anticoagulation for what's considered sort of a provoked amount of time and do well. So in either case, we continue to recommend the COVID vaccine. Okay, we do have to finish up. We will try to take a question. Any recommendations for dealing with the mental and psychological aftermath of a clot and being diagnosed with a blood clotting disorder? It seems like many people have post-clot PTSD or anxiety, and there are not many support groups.
Do you want me to answer that?
Yes.
Yes.
Yeah, so for the first couple years, I mean, I did have a lot of anxiety, especially around driving, because I luckily, when I had my strokes, I was at home. You know, but my biggest fear would have been, you know, being behind the wheel and having that happen and, you know, hurting or killing someone else or myself, or, you know, and just knowing that I had, and still, you know, I've come to terms with it more, but still, you know, having the anxiety of knowing that there are clots in my brain and that, you know, that they could, you know, at any time break off if something happens. And, you know, they at first put me on anticoagulants for just 6 months. And that was what they said was protocol. And then they took me off of them. And then my clots started to grow. So then I was put back on them and I was put on them for indefinitely. And so, yeah, I mean, after a couple of years, I did find a few support groups. And that was around like 2019. And then unfortunately COVID happened and then they kind of ceased because they're in hospitals and stuff. But, you know, there are some support groups, but I was finding more support groups through stroke. And, you know, I'm kind of in this niche area where, like, if you go to a support group for strokes, like, not a lot of people with strokes have the CVST. And then when you are working with, like, you know, people that just have blood clots, anxieties about that, you know, it's not, then my issue is different than that. So I was just kind of trying to find a support group. Does help if you can find one that, you know, deals with your issue. But it's normal to have anxiety because it feels like you have like a lack of control over your body, and that's why it can be frustrating with, you know, dealing with different doctors and all the, especially when you have a complicated thing, all the different doctors that you have to see and trying to get everyone to work together and that way. So.
Yeah, that sounds like you really had to navigate a lot and also been advocate for yourself and find the right space. The NBCA is also dealt with that with a lot of patients, and I'm sure Dr. Kouides, as well as myself, we really do see that with patients. It does really feel, some people think, oh, you had a blood clot, you know, sort of over with, but it really does feel like having a chronic condition, you know, and a chronic disease in some ways, and it doesn't end. It's really a lifelong battle in many ways. You can find out more on the NBCA website about the Kouides study, which also just looked and examined this and surveyed a lot of patients about feeling like they had post-traumatic stress disorder. So there is a lot more out there, and patient resources there too that I think could help. And again, I thank you, Catherine, for sharing your story today. It was really helpful, and all the patient questions showed that too. So we do have to wrap up, unfortunately, and the fact that everyone stayed on past 2 showed how interested people are in all of this. So I wanted to thank Dr. Kouides, thank you, Catherine, thank you everyone for all of your interesting questions. We did not get to everything, but we will try to answer everything else via email. And thank you so much for everyone's attention today. You will also get an email. Please respond with your feedback and comments. Please check out the website, stoptheclot.org. And thanks for joining us today, and have a great afternoon.
Thank you, everybody.